Well, good morning. I promise you no molecular stuff this morning. I was asked, and I thank the organizing committee for inviting me to talk about the critical part of deciding whether mitral regurgitation is severe or not. As we know, especially those of us who deal with echocardiography, the criteria are many. And when you have so many criteria, one must assume that none is perfect. And indeed, when you look at the current European guidelines for valvular heart disease, you can see that the diagnosis of severe mitral regurgitation, which starts the decision tree process, is dependent on echocardiography. We don't start talking about mitral regurgitation and whether to repair it or not when we assume that it's not severe and we look for different etiologies for the patient's condition. So are you confused? I am too. So let's dissect, or try to dissect in the short time that we have one by one, the criteria that have been recommended by the European guidelines on assessing whether mitral regurgitation is severe or not. And the first criterion appearing on the guidelines is the anatomy. And we know that we have several clues in the anatomy that may suggest that MR is severe. For example, if you have a flayed segment, more than 80% of these will have severe mitral regurgitation according to published literature. The other etiology, as you saw in Chaim's lecture, is apical tethering from functional mitral regurgitation. When you have more apical tethering, you have more MR, as been nicely demonstrated by Francesca Nesta from our group a while ago on the paper in JASC. You see this tethering area, which is directly related to severity of MR. And of course, we have other issues like whether we have a perforation that may suggest that MR is more severe. And I'm not talking at all about prosthetic valves, but in a prosthetic valve, for example, valve dehiscence might suggest the same thing. Now, the next thing that we all look at, all of us, is the color Doppler, and that's actually the most common technique that everyone uses. And the eyeballing mechanism that we all train to use is to see where the distance of the color Doppler goes inside the left atrium. So, and this is a very old technique, and this is actually been published in Japan in 1986 with the very early color Doppler from Aloka that was still a prototype. And you can see that there was a good correlation. They found 100% specificity with the current gold standard of the time, which was ventriculography. Other groups try to improve on that, and I'll show you in a minute why it needs improving. For example, another group, and this comes from the Mayo Clinic, actually tried to see whether the jet area is correlated with severity of mitral regurgitation, again using ventriculography as the gold standard. And you see that there was a very good correlation when you try to do a maximal ratio of area of the jet to the area of the left atrium. And of course, the caveat to that is that left atrium changes as mitral regurgitation progresses. You have severe mitral regurgitation, generally you have larger atria, and this all changes this ratio completely and skews it. So another thing is, of course, that everyone knows that when you look at color Doppler, you look at velocities, you don't look at volumes. So the relationship with regurgitant volume is not linear. It depends also on driving pressures. It depends on chamber compliance. And this is a very strong caveat because those patients may have diseases of the other chambers. Now, there are other issues. This jet actually entrains. When you have a central jet, it entrains more blood around it. It just pulls it together. So actually, central jet, again, the work from the Mayo Clinic comes, a central jet may seem more severe than it is really when you look only at the color Doppler. On the other hand, jets that are eccentric, and especially those that hit a wall of the atrium, are severely its severity is underestimated, and this is a work coming from the Mass General, from our group, actually showing that whenever you have a free jet, the correlation between jet area and severity of MR is maintained but when you have a wall jet, this correlation goes away and the p-value is non-significant. And this is actually coming both because of jet distortion when it hits a wall and what we call the Coanda effect, or momentum transfer of the jet, of the velocity of the jet to the left atrial wall. And of course, as we all know, color Doppler has a very significant inter and intra-observer and even day-to-day variability when it's being assessed. Now let's look proximally to the color Doppler jet. And we look at whenever you have fluid condensing into a small orifice, you have concentric, theoretically hemispheric areas that have the same velocity, and those areas contain the same amount of blood that flows later on in the narrowest part of the regurgitant valve, and this is according to the law of conservation of mass. And you've seen this diagram already on Professor Yosefi's lecture, but you can see actually that we can define these concentric, and I don't have a pointer, excuse me, these concentric areas that condense into the Vena Contracta, which is the narrowest part of the jet. And of course, when you have a round orifice with flat margins, those are initially hemispheric, even though, you look at this work, they tend to flatten as you approach on the valve. So the hemispheric assumption is only true at a distance from the orifice, not close to the orifice. And this is, again, for a perfect round orifice with flat surfaces. But as Chaim Yosefi has nicely shown to you, the mitral valve is saddle-shaped. It has a semilunar orifice, it's not round. So the assumption that we have this perfect hemispheric shape, and you've seen that already in Chaim Yosefi's presentation, is not true. And this is, again, a work coming from Min Pu when he was in Mass General, showing that if you have a 3 centimeters profile asymmetry of the incoming orifice, you get, and I point to you to the, here it is, sorry. To the left panel, you can see that the dashed line is the ideal flow rate as would we measure in an ideal surface, and you can see that the little dots, the full dots on the top, and I'm sorry that I cannot point it to you, are very much away and actually are interpreted as representing a higher flow rate. And of course, as Chaim Yosefi has shown to you already, and has saved me the trouble of showing you his nice pictures from his paper, the proximal acceleration is rarely hemispheric. So how can you use this PISA? The one thing that one can use is use it as you use the color Doppler jet area. Qualitatively, just by looking at it, you can see that whenever you have a mild MR, the PISA is small, and you have severe MR, the PISA is large. And you can see it very nicely. This is a panel coming from the European guidelines. You can see in panel A, mild MR, in panel C, severe MR. And you can see that the proximal acceleration area is larger when MR is severe. But we can use it, and this is the most common use of it, we can use it quantitatively. And actually, we can use it to compute effective regurgitant area and regurgitant volume. And the recommendations in the guidelines tell us, as Chaim has shown you already, to use the mid-systolic PISA. This is the old method. I won't go through it really for echocardiographers, but you can see that the formulae are very simple. You know, when they are simplified, they're very simple to use. And they give you a number. I actually give you 2 numbers, effective regurgitant area and regurgitant volume. Well, if it's so nice, why it isn't so nice? Well, first of all, we have timing problems. MR is not one disease, it's several diseases. And you can see here 4 panels of color emerald through the Vena Contracta of mitral regurgitation, showing different types or different etiologies of mitral regurgitation. Panel A, for example, is ischemic type or functional MR. And you can see that actually the mid-systole has the lowest PISA. The largest PISA comes in early and late systole. You can see, for example, panel D, which is mitral valve prolapse. And mitral valve prolapse shows the maximal PISA at late systole. And also we know that because we listen to the patients in either the late systolic peaking murmur. So this is one type. The other problem is that we have a resolution problem. It's very, very operator dependent. If you miss by several millimeters the true PISA, your error is squared because you measure the area. So that's another error. And as Chaim has shown you, a possible solution would be to measure the PISA in 3D. And actually, there are some vendors that went already one step further that do averaging of the PISA throughout systole and also measure the PISA itself by 3-dimensional echo, which actually may overcome some of the problems that we've shown. The next criterion in the guidelines is the Vena Contracta. The Vena Contracta, as I showed you, is actually correlates very well with the effective regurgitant orifice because it's co-localized. We measure the same thing, theoretically at least. You can see it in this diagram very well. But as Chaim has shown you already, and I quote him again, it's not round, it's not symmetrical. So actually the measures that we use to measure the Vena Contracta diameter in two-dimensional echo should be average at least to overcome a little bit of this problematic. Again, as I've shown you and I repeat this slide, the timing is critical. Which Vena Contracta do we measure? And it depends on which type of mitral regurgitation do we use. And we have to pay attention that we don't measure automatically the mid-systolic one. In the published work, there is a very large overlap between the criteria used to define mild and moderate and severe mitral regurgitation using the Vena Contracta. And we need, again, to take this caveat into consideration. Measuring it, as Chaim has shown in the 3D domain, might be the solution. And here is a nice work coming again from our group at the Mass General showing that there is a very good correlation between the two-dimensional echo measured regurgitant area using the Doppler-Doppler method that I show in a moment, and the Vena Contracta as measured by three-dimensional echo. Now, the next criterion in the guidelines uses the spectral Doppler. And we know that continuous wave Doppler of mitral regurgitation, because the spectrum of the Doppler is directly correlated with the density of erythrocytes flowing at a certain point in time, the density of the continuous wave Doppler is directly related to severity of mitral regurgitation. And as you can see here, in the third panel, you can see that as mitral regurgitation progresses to be more severe, the continuous wave Doppler becomes denser. And actually, there is another nice sign, which is called the cutoff sign, which is actually demonstrates whenever there is equalization of pressures between the left ventricle and left atrium in late systole, also signifying that MR is severe. Another thing that you can see here actually is another criterion which is mentioned in the guidelines, which is the inflow pattern. As you can see it in the second panel, the inflow pattern of the left ventricle. The E wave becomes more and more dominant as MR becomes more severe. So actually, I can quote one authority, a good friend of ours, that says that actually when you have a dominant inflow pattern, it actually almost rules out severe mitral regurgitation. But typically, severe mitral regurgitation, because of the high filling pressures of the left ventricle, is associated with E dominance and a short deceleration time. Another sign that's mentioned in the guidelines is using the systolic blunting and reversal of the pulmonary venous flows. And again, this has been actually described as the echocardiographic V wave. You can measure the flows in the pulmonary vein inflow into the left atrium. And you can see as progressively left atrial pressure rises because of the mitral regurgitation, the S wave becomes more and more blunted. Actually, it reverses when MR is very severe. And this sign is a very useful sign to see the significance of mitral regurgitation, the hemodynamic significance of it. But one has to point out that this is also associated with any reason that would raise left atrial pressure. So if the patient has only moderate MR but very severe, for example, diastolic dysfunction of his left ventricle with a compliance abnormality, this sign would also occur. Now, the spectral Doppler is also used as what is described as, quote unquote, the echocardiographic gold standard of measuring quantitatively mitral regurgitation. And this is just by subtracting the forward stroke volume as measured as we measure in the continuity equation using the LVOT area multiplied by the velocity time integral at the LVOT from the total stroke volume, which is computed either by using the same principle on the mitral valve annulus, and again, not the point that you measure the LV inflow, but really at the annulus, or by subtracting end systolic volume from end diastolic volume by using the biplane-Simpson method. And this is, as I said, is considered the echocardiographic gold standard. This is, you see here, a graphical representation of what I just told you. So this is in theory the gold standard, but actually it's prone to many geometrical assumptions. For example, the The worst assumption is that the LVOT and especially the mitral valve annulus are assumed to be circular, and they're not. So you need to do a compromise by measuring two radii and doing the average. And if you use the biplane Simpson method, again, all of us are aware of the errors of this method. So this is not an error-free system. In the European guidelines, there is an interesting quotation from a paper from Triboulois in 1994. Actually, this method has not been repeated since, but using the ratio between the mitral valve VTI, velocity time integral, and the LVOT VTI, disregarding the areas where they flow. And of course, this is very problematic, as you all guess, because we know that one of the mechanisms by which MR begets MR is annular enlargement. So we cannot assume that the annulus is fixed and compare it. And of course, the original work by Triboulois was validated only with patients with no aortic diseases, nor mitral stenosis, which all can change what affects this formulae. So we come back to the guidelines, and we've seen, and we've gone over most of the methods that are in the guidelines, and we're still left with a conundrum. What can we do? And what I advise you to do is to use the Gestalt method. It comes from psychology, basically looking at the whole picture. Do not stick to one method. Do not say, okay, this patient has severe MR because he has an effective regurgitant orifice area above 60, but above 40, sorry, but use, okay, he has an effective regurgitant orifice area above 40, but his Vena Contracta is small. Or on the other hand, he has an effective regurgitant orifice area less than 20, but he has two jets. He has a cross-sort pattern, for example, of MR. So he has another piece that you didn't take into consideration. So we need to take the whole picture, and don't forget that we're dealing with a patient, and we need to keep in mind what the clinical presentation of the patient. And this is one, and there are many flow charts that have been proposed. This comes from Catherine Otto's textbook that actually shows you a nice way to integrate all those things. You know, you start with just looking at the color Doppler, as we all do, and when you're sure that it's not mild MR, then you go and measure the Vena Contracta and deal with the conundrums related to it. 2 minutes. Nelson Schiller's group has proposed in 1999 an index, actually giving a number to this Gestalt thing. It includes also the pulmonary artery pressure and other measures that we didn't talk about, but they validated against a group with pure mitral regurgitation. And of course, when we have multi-valve problem or mitral problem with a ventricular problem, it might not pertain. And of course, in atrial fibrillation, again, those patients were excluded from the study. It's not, I don't advocate to use this index, but it's actually a nice framework for us to think about when you speak about this Gestalt issue. So what will come in the future? As I told you, my current advice is use the Gestalt principle. Use three-dimensional echo as much as possible. Gain expertise into it, know what you can take out of it, and use it as much as possible because it takes out many geometrical assumptions. Some methods have been proposed to technological method to overcome it. I just mentioned two here. Both are very old. The most promising one is the backscatter Doppler powered Doppler velocity integral analysis proposed by Thomas Bach. It necessitates special hardware, but it's still a challenge to the echo companies to develop, to use this method to develop it, because it is the promising non-geometrical assumption-based method to analyze mitral regurgitation. So in conclusion, there are myriad methods to assess mitral regurgitation severity by echo. Most are at best semi-quantitative. The quantitative, or I should have put it in quotes, quantitative methods suffer from limitations due to human, machine, and valve geometry factors, and only an integration of a maximal number of parameters may provide a reliable assessment of mitral regurgitation severity. And of course, a three-dimensional valve needs three-dimensional assessment. Thank you very much.
Thank you very much, Ronen. I have one remark, is you should also look at the size of the left ventricle and the left atrium and the pulmonary pressure. And if you think that there is a significant MR, but you find that the left ventricular size is normal, the left atrium is not dilated, and the pulmonary pressure is normal or near normal, then something is fishy. So look also at those parameters.
That definitely comes into my Gestalt framework. Thank you.
Okay. I'd like to ask you, you've shown eloquently all the methods and the limitations, and it's clear that echo is a main tool for assessing mitral valve mutation. Could you comment on the tendency still of cardiologists in borderline cases of MR to use the left ventricular injection to quantify MR? What do you think? Is there any role? If yes, when?
I'm going to get in trouble with my cath friends here. I think that originally this was the only thing that we had in hand to analyze mitral regurgitation, and it was considered the quote-unquote gold standard because people didn't have anything else. I don't think that's relevant anymore. Most of us do the left ventricular injections in a single plane method, not in biplane. We are missing eccentric jets, and the load of contrast material that's involved in this injection, in my personal opinion, does not justify using it anymore. And I don't think that using the whole picture as we spoke and getting to a conclusion about severity of MR, that an injection would change significantly my mind. Also, one has to know that MR and specific types of MR are dynamic. They change with blood pressure. You have this patient lying down, getting sometimes sedatives, on the other hand, getting fluid overloaded because of contrast material and fluid given for catheterization. The hemodynamic situation is completely different. I would not, taking all the risks and benefit, would not advocate using it as a method to analyze MR in this modern day. I would prefer, if you have a question, to get another data, for example, from MRI, and not go to contrast injection.
Okay, thank you very much.